side of things, especially in our radionuclide space, has really leapt ahead in the past decade or so. I'd argue before that, all the action was in the physics and the instrumentation, because we had the emergence of PET-CT, we had the emergence of SPECT-CT, and for those nuclear medicine physicians and practitioners present, you know that that's revolutionised the way you do nuclear medicine. So physics hasn't advanced a whole lot while the chemistry's been racing ahead of us, and it's time for us to catch up. And I think we're starting to make some movements in that area. So I see us in our little world of nuclear medicine sitting at the centre of this wonderfully multidisciplinary group of individuals and disciplines, like Amos has alluded to, the sort of the multidisciplinary nature of all this, but we really do interact with people involved in all the areas that you can see on this. This is my molecular imaging molecule with the radio tracer right at the centre of the whole thing. But it's important for us to be able to interact with everybody, and it's great that it's such a multidisciplinary group here today, because it has to be to meet the aims that we're all heading for. Traditionally in radionuclide therapies, where again we haven't had much evidence, we've just practiced along certain taught themes, we can start, and we started in the 1950s with radioiodine, with little or no patient-specific information. Everybody gets the same capsule, no matter how much disease they've got, no matter what size they are, any other parameters. Very little prospective dosimetry. The only group that has pushed this very hard in radioiodine has been Memorial Sloan Kettering, and again there's not much evidence that it makes much of a difference in overall survival. So you can start with that sort of approach. You can use a little bit more information, and so Certex, another Australian company with a radionuclide therapy, promotes the use of modifying the dose based on the body surface area, but really, again, very little information about disease burden, whether the patient's had prior resection of any of the liver and so on. So a little bit more information, but not much. And both of these methods don't take a whole lot of effort to calculate that number. But you go to the other extreme, so our radiation oncologists today spend hours poring over CTs and MR scans and planning how they're going to dose paint to deliver precise greys to certain tissues and boost certain areas. And the key thing about this, as you move from one end of that spectrum to the other, you need a lot more information, you need a lot more imaging, you need a lot more time, you need a lot more expertise from very highly specialised individuals. And at the moment, where we are with lutetium is down here still, as a number of the speakers have alluded to: standard dose, independent of disease burden, standard dosing intervals with no real good evidence for that. So what we'd like to do is really to move lutetium dotatate from here somewhere up in this sort of domain. So what are the tools we require to do this, to better inform how we plan our therapies? We need to look at the biodistribution over time. Copper-64 is a great example for us to be able to do that. And the other thing is it's three-dimensional, it's a PET agent. Doing anything with gamma cameras and whole body distributions with planar 2D images is really very inferior. And interestingly, the copper-64 sartate study that we did with Clarity was the first time I've ever worked with three-dimensional biodistribution data. We've never had that opportunity before. We've been stuck in 2D planar imaging, and it's really difficult to separate our kidneys and livers and spleens on images that are compressed in that third dimension. And we need to also remember you've got to administer the radionuclide under the same conditions as for treatment. So if I was to do dosimetry and we were using amino acids, you'd argue that you probably need to do that dosimetry on amino acids. So that's another level of complication and impost on the patient and the department. We need quantitative 3D imaging. Now, we know that that exists for PET. We've always had that. And in fact, yesterday, Royal North Shore qualified our PET camera as being quantitative for copper-64. So this is really a great way to do the dosimetry. In SPECT, which has been my strong area most of my career, we now are at the point where some of the radionuclides are quantitative. Certainly technetium is. We've done a lot of work with lutetium in that space, and we've made that quantitative, and we had the opportunity with Clarity to work on quantitative copper-67. Because it's a beta emitter, beta emission is usually accompanied by a gamma emission, and that gamma emission is what we can then use to image the patient, be it I-131 or copper-67 or lutetium-177. And we want to move to VOXEL-based dose maps So we want to have software that takes images of biodistributions in 3 dimensions and turns them into a biologically equivalent dose in grey that we can then interpret and modify to reach a certain prescription, or to look at things, the normal tissue, such as bone marrow or kidneys or salivary glands, and then to make sure we don't do any damage to those organs. So in terms of biodistribution over time, I think there's 2 approaches we can take. One is to perform a planning study, so you do the whole thing with the amino acids and everything else that you might do under the same conditions as for treatment, and certainly for the kids study, that's probably what you would want to do. Or the alternative is just use your first dose, as we do today, as a standard dose, and do your full modelling on that and your biodistribution over time, and then modify subsequent cycles based on that. That's got to be a lot easier to do, and it's probably the approach, if people were to do biodistribution studies to plan and personalise these treatments, that's probably the way most people, I think, would do it, because at the moment we're doing that, we're just doing it at every cycle, so it makes sense. The suitable candidates, if you look at it, in PET we've got copper-64 with its long half-life, not gallium-68, we can't use it for distribution. Gallium-68 dotatate just tells us about targeting. It doesn't tell us about retention and biodistribution over time. Yttrium-86 to go with yttrium-89, and zirconium-89 can be used also as a good PET imaging agent with a long half-life. There's iodine-124 with a 4-day half-life, which is what is used at Memorial Sloan Kettering for every thyroid cancer patient to do their prospective dosimetry. And that also can be, radioiodination is very ubiquitous. You can label lots of different molecules, obviously with iodine. You can then pair that with I-131, of course, as the therapeutic. In SPECT, we've got indium-111, but we'd all like to sort of forget about that. And I was reminded in the first talks this morning there was an indium-111 prostacint in the 1990s. I mean, it's gone the same way really as Octreoscans should go. I don't think anybody does those anymore. Iodine-123 with a similar half-life to copper-64. So again, we could be doing quantitative SPECT with that. 131, which we can use, of course, although it's not ideal because of the very high energy gamma radiation. And the candidate that I think is really interesting is perhaps a rediscovery of gallium-67 because of all the work that's been done with gallium-68 for PET, the chelation, the DOTA linkages and all the rest of it, or the NODAG or whatever you're using as the chelator. Gallium-67 would work just as well. It's got a 3.5-day half-life. It's got lovely gamma ray imaging characteristics, and I think for sites that don't have PET, or maybe jurisdictions where gallium-68 generators aren't allowed, then gallium-67 could be a real alternative to using gallium-68 labelled octreotate or whatever. In PET, we've got Y90 we can image the positron from pair production in Y90, and we do that regularly with our SIR spheres. But most of the therapeutics you can see are SPECT agents, and for that reason quantitative SPECT remains a really important thing for us to have. SPECT is not going to go away because it's linked to every therapy. So copper-67, I-131, lutetium, and then also things like P32 and yttrium-90 can be imaged also on the gamma camera where there's no gamma emissions, but you actually image the scattering of the radiation, the Bremsstrahlung radiation, as the electrons move through the media. They give off a continuum of radiation that you can image. It's not high quality, but you actually can get a lot of signal from it, so that is an alternative. So that's how we can look at biodistribution over time. We want quantitative 3D imaging. PET, it's a give me, and this is one of the studies we got from Amos and Clarity. This is a late time point, copper-64 SAR-Tate scan, and I was kind of concerned when we started imaging with copper-64. It's only got an 18% photon fraction, whereas fluorine-18 is 97%. Gallium-68 is 89%, and this was 18%, so we're only getting like 1/5 of the signal. But the thing is, there's no decay virtually over time when we're imaging over the first day at least, and so you retain pretty much all the activity that's there, whereas we had a look recently at some of our gallium-68 dotatate scans, looking at the total activity in the whole body when we image them at 1 hour, and it's like 30 and 40 megabecquerels, even though we've injected 160 or 200, because you've gone through a half-life. So you're down from, say, 160 to 80 megabecquerels, and then you've had elimination via the urine as well. So we really are dealing with a very low total amount of activity retained because of that short half-life. That doesn't have the problem. It only has the elimination via the urine. And so you can image for quite a long time. And again, working in 3D like this, we can do dosimetry on the pancreas, which we've never been able to do on a planar 2D scan before. That's what the planar scans look like. This is a gallium-67 antibody that we're working on with a company called Monomic. This was from the World Congress of a couple of weeks ago, just showing you out to day 7 the excellent imaging quality that you get with gallium-67, and I think it's a real candidate for doing quantitative SPECT with. So here's an example of showing the targeting of gallium-68 dotatate, of course, and here's our standard planar whole body imaging, which we do our dosimetry on. So we try with every patient to image out to day 5. So we image on day 0 a couple of times, day 1 at 24 hours, and then they come back at day 5 for the final time point image. This is only 93 hours, but we've modified that just for logistical reasons to go out to day 5 now. And with that, we're able to generate these time activity curves after we segment out the organs, and then we can get dosimetry and look at dose maps in grey, just as the radiotherapist would. So there's lots of different packages available today that the physicists can use. Some of them are still organ-based, some of them get down to voxel-based, and that's really the way that we're heading once we've got 3D data. The theranostics are becoming sort of individualised as well. The long-lived traces that are becoming available, all these things coming together. We then require cooperative patients because we do need to look at them at multiple time points. It does appear to be highly reproducible. We've done many studies at North Shore looking at 4 cycles of lutetium, the whole body retention, the organ retention, and it's very, very reproducible in these patients. So possibly we could do intensive imaging at the first cycle and then use that for all subsequent cycles and not have to have the patient come back all those number of times. There are some other unanswered questions, and something Nat and I talk about almost every time we meet. The radiobiological issues of low dose rate irradiation. This radiation does not treat in the same way that external beam does. The external beam is giving 2 gray per hour over 10 seconds, targeted areas using megavoltage X-rays. We're using particles that are coming out at a very slow rate in the scheme of things. So there's a lot of time for single-strand break repair and DNA, whether we need to start thinking about whether we can inhibit that process to get more effect from that radiation, whether we can increase the radiation, and this silly 23 gray limit that people talk about from external beam certainly doesn't seem to have any basis for any decision-making in dotatate therapy. So it's a big issue, and in our department we're actually going back to the lab, to basic wet lab, and setting up platforms of different cell lines, looking at different irradiation profiles and different co-administration of other drugs such as PARP inhibitors to see if we can actually affect that. We don't know much about the frequency of treatments. I believe the 8-week cycles that we're on at the moment is because that's how often the patients used to come and see the doctors at Erasmus for follow-up. There's no other basis for it. And certainly there's people like Sandy McEwen in Calgary who are treating on 3 monthly with lower doses in a maintenance sort of dose regime rather than 4 cycles and sit back and wait. So there's not much evidence for any of that at the moment. And again, Nat in particular alluded to the combined use of radionuclides and chemotherapy. So we're working through our issues in the physics side. Most of them are under control. SPECT is always going to have this problem of the limited spatial resolution. We've recently determined that the spatial resolution of our lutetium imaging with SPECT is 20 millimetres. That's the measure of the resolution. Now in PET it's 5 millimetres. So I'm really comfortable when we do dosimetry on kidneys that the dosimetry is right. But if we're talking about nodal disease or lesions that may be 2 centimetres in size, I think we're underestimating by an enormous amount, and we need to be able to deal with that. So, I've stopped working, or that was the last slide. Anyway, it's probably a good place to stop. Thanks very much.
But, I'm coming back to a practical thing, a question that is often asked by colleagues, by patients. Most patients start on somatostatin analogs. So when they come and see you for PRRT, they are on a somatostatin analog. Should they continue on the somatostatin analog, or should they take it out before starting PRT?
So the common practice, I think, is to suspend the somatostatin analogue or have it as far as you can from the last injection of the long-acting agent. So hopefully at about 3.5 or 4 weeks, you come and have your scan or your treatment. I think, Nick, you tend to keep people on the somatostatin if it's doing them some good, don't you?
Yeah, well, if they're symptomatic, it's difficult because we've had a few people coming with very poorly controlled carcinoma and had a couple of crises, had to go to ICU. So our hand was forced. We were having some people on 2-weekly intervals and then had to give short-acting on triatide. And then we would start a 24-hour continuous infusion post-lutate. So it was driven by need. I know what you're getting at. We don't know whether it interferes or not. It's all purely hypothetical.
So we do have a trial that we're going through getting ethics approval for at the moment to study, firstly, the reproducibility of dotatate imaging, because that's never been defined. Yeah. So, say, 2 days apart or a day apart, do we get the same SUVs? What's the significance of the SUV? And then, secondly, we're going to give them their long-acting dose of somatostatin and bring them back at day 3 for another gallium-68 dotatate scan to see if that shifts around any of the uptake in any of the organs. Because potentially, we're talking about the sink effect, you might be able to get more to the tumour.
Yeah, because I'm alluding on our study, Velykan is the first presenter, and when we were giving standard dose of somatostatin before doing the scanning, we could see that the uptake in the tumor increased, whereas the background normal tissue and so decreased. Yeah. So I think, and that has not been observed so much and not discussed in detail, and not. So I'm happy to see that you are starting to look into it now.
Yeah, especially we're selecting patients who have been recommended for lutate, so they're going to get large radiation doses. So we're not worried about 2 extra small doses from the dotatate. But I think there were 2 or 3 posters alluding or addressing this at the ENETS this year, and that was really marginal whether that had a big impact or not. There's also a paper from the Austin people here in Melbourne. So Ziting Lee was one of the lead authors on that. But they looked at people who kind of forgot to go off their lanreotide and had imaging 9 months apart and said that it didn't affect them very much. So I think we need to do it controlled and do it properly.
Absolutely.
Bill.
Wrong question to ask to an academic, but if we're talking about routine clinical dosimetry, that's a significant volume of work for most centres and also potentially a significant inconvenience for patients. So what's your view on single time point dosimetry? It's been, I think, partially validated with PSMA if you do a 4-day scan. Yep. And as an extension to that question, 24 hours or 96 hours? So,
again, this is something everybody's obviously very interested in. We've been trying to collect the data at every cycle into completeness. And we've had a lot of support from our department to do that. And it is a punishing schedule. Therapy day is a busy day with people jumping on and off cameras all day. We think that, so looking at our data, we are happy to use the first profile that we get of biodistribution and scale it by the 24-hour time point at all the subsequent cycles. I think also our clinicians would probably be happier looking at a 24-hour lutate image than a 4-hour image, just to get a feel for how the patient is going. So I suspect we'll ask them to come back on the following day for imaging. Michael Lassman's published a paper recently showing that 96 hours was better than 24 hours, but I don't think there was too much in it. And we're certainly happy that our results are plus or minus 12% error, we think, using a single time point on subsequent cycles 2, 3, 4, based on the results from cycle 1. And that's probably the way we would go.
So complete profile cycle 1,
yep.
24-hour imaging subsequent cycles.
Yeah, a lot of people have tried to assume a slow half clearance time, but it's the fast clearance that really does vary quite a lot, and that's probably dependent on GFR. Yeah, Nat.
This is probably more a question for Professor Obu. In Europe now, it's mandated, I believe, that dosimetry has to be part of every therapy. And if that's the case, is there reimbursement for doing the dosimetric analysis?
I mean, I must correct you, it's not mandatory to make a dosimetry. I mean, there is still an open discussion about how to do. But in many centers, they are not doing any dosimetry. They are giving 4 cycles full stop. But we have been doing dosimetry for all the time, more than 500 patients now. And I must say that in Sweden it's not a problem. It's reimbursed. The problem we see is that if we get patients from, let's say, Norway or Denmark or Finland, then we run into a problem because they don't want to pay for the extra days. So, but in Sweden so far it's reimbursed. I don't know exactly if it's reimbursed in other European countries at the moment.
That's an issue in this country,
Yeah.
because
Good.
we don't get any reimbursement for subsequent imaging or the physicist's work.
And also, we're going to have a look at it, but we think a very large proportion of our patients are coming from regional centres rather than metropolitan. I think we have to finish this session because we're sort of at the end of what we're meant to be for the end of coffee. Dave, how do you want us to let the program slip?
Still take 15 minutes here.
Yep.
Break, to make time on the other breaks.
Yep.
It's good to change around the room a bit, so we can stop now. Do you want to take a photo of the speakers there? Do you want to do that on the break?
At lunchtime. Okay. As long as Ben's still here for it. Yeah. So we meet back at 11:20. Thanks, everyone.